So we've heard about SBRT and we've heard about LDR brachytherapy, so now we're going to move on to HDR prostate brachytherapy. These are my disclosures. Dr. Blacksburg went through all the radiobiologic stuff very well, so I don't have to repeat that. But just to summarize, the low alpha-beta ratio for prostate cancer favors a large dose per fraction. There are several technical advantages for high dose rate prostate brachytherapy. You can get exquisite dose optimization through manipulation of the source dwell positions and durations. There's no organ motion or setup error. There's no seed migration, and there's no alteration of delivered dose because of edema. It's also very economical because you use one little tiny Iridium 192 source for multiple patients, multiple treatments over a 90-day period, and then you replace the source. I do mine under general anesthesia. You can see the needle insertion through the template under live ultrasound guidance. Once the needles have been positioned to mid-prostate, we advance them individually to the base of the prostate and then lock them in position in the template. When all the needles have been positioned at the base, then we track that needle so that we know not just where the tip of it is, but the whole track of the needle. I use steel needles, so they're quite straight. If you use plastic needles, you can have a little bit more variation there. Take a set of images for treatment planning, contour the prostate, the rectum, the urethra, and then do our inverse planning to plan the dose distribution. You can shape the isodoses around the urethra. We limit the urethral dose to a maximum of 115% of the prescribed dose. The other important feature here is the prostate's contoured in red. We treat with the probe in, so with each time we give HDR brachytherapy, we've pulled the rectum down and the prostate moves up in the screen, and we increase the space between the rectal wall and the radiation. This just shows an image of the prostate with the needles in place and the transfer tubes all connected and ready to treat. When you're selecting patients for HDR brachytherapy, there are a few types that you might want to think twice about. Very large gland size, over 70 to 80 cc's. It can still be done, but they really need stellar voiding, and you have to verify the pubic arch. A TURP within 3 months of treatment. I've done them at longer intervals with no adverse effects. If they do have poor voiding with a symptom score over 20 or obstructed voiding or retention, you should correct that first. Obviously, if there's significant pubic arch interference, that can be an issue, although we can get away with very good implants for quite significant pubic arch interference using HDR, I think much more so than I've been able to implant with LDR, simply because on those dwell positions that are under the arch, you can throw dose further. Patient obviously has to be able to get into lithotomy and be fit for anesthesia. Now this is where LDR and HDR results are very, very different. LDR has had the same dose since day one. It's 145 gray, and it hasn't changed. So we have this wonderful 15-year, 20-year data, and for the boost, it's been either 110 usually, or the Ascend trial at 115. So there's very, very great uniformity there, which is really helpful. HDR has been in evolution since day one and is still in evolution. So when HDR was first started, sure, it was a large dose per fraction, but it was 5 or 6 gray. And it was given in multiple fractions. So it moved from multiple smaller fractions to fewer larger fractions. It's moved from overnight hospitalization with needles and catheters in place in the prostate to an outpatient procedure. It's moved from only being used as a boost in combination with external beam to now being used as monotherapy. And it's moved from CT-based planning, which takes about 6 hours per patient, per treatment, with multiple patients, transfers, and movements, to ultrasound-based planning, where the whole procedure and treatment is done in less than 2 hours. without any patient movements. So how did this evolution in fractionation and dose take place? This is a table from Alvaro Martinez, just looking at it. This is for HDR boost treatment, the BED of combined external beam and the HDR, using an alpha beta of 1.2. And so initially it was 3 fractions of 5.5, 3 of 6, 3 of 6.5, then they jumped to 2 fractions of 8.2. And you can see here, when you add that to your 46 gray and 23 fractions, this is what your total BED is going to be: 215, 230, 248, 253. It appears that the magical cutoff is at 268. And once you get above that, you get really, really good control rates. But Alvaro kept progressively increasing fraction size to 9.5 times 2, 10.5 times 2, and finally now our accepted boost dose is 15 gray in 1 fraction, and when combined with 46 in 23 of external beam, that gives us a total BED of 272. The 10-year results by BED dose level that he published back in 2011. Here you can see for BEDs over 268 and under 268 in blue, for disease-free survival, distant metastasis-free survival, BNED rates. It's quite consistent across all the endpoints. So now I'd like to just update you on HDR results that have been reported in the last 18 months. There has been a deluge of data coming at us in the literature. Most of these papers are from 2017. There's 2 from 2016, involving over 5,000 patients. This is for HDR boost, so these patients were all high risk and intermediate risk. The majority of them, except in Japan and Quebec, also had androgen deprivation therapy. You can see in some of the reports the progression of fractionation from 3 fractions to 2 fractions to 1 fraction, and the external beam dose is fairly consistent. The follow-up periods are from 5 to 10 years. The Japanese report goes out to 17 years, so we're getting quite respectable long periods of follow-up there. If you ignore or disregard the 2 reports of relatively low dose treatments, Joseph's report used a single 12.5 gray as a boost, and Yaxley used 3 times 6.5, and we know those BED combined are too low, so if we forget about those guys, for intermediate risk at the 5 to 8 year mark, we've got control rates, BED rates of 91 to 97%, and for high risk it's in about the 85 to 93% range. So this is getting respectable. If we look at the toxicity from these treatments, in general, the GI grade 3 toxicity is well under 5%, running at like 2 to 3% or sometimes nothing. If we look at grade 3 GU toxicity, it can be higher. It runs about 5%. In my own experience, is 3%. The majority of these are strictures. The majority are in the membranous urethra, and there are occasional reports where you have a 30% stricture rate, which, when recognized, is suddenly eliminated. And that's in Yaxley's report here is one of those examples. Up until 2005, they didn't do their planning correctly, including too much tissue below the apex of the prostate. So 29% stricture rate, which subsequently became 4. Even Alvaro Martinez went through this. He had, I think, a 15% stricture rate in his early years, and then changed his planning, and it was down to 2 or 3%. So obviously where you deliver the treatment is extremely important. Now if we look at monotherapy results, monotherapy was much later on the scene. We don't have 17-year reports for people using HDR as monotherapy, but the fractionation progression is even more striking. Again, here, all these papers are from 2016 and 2017, and it's 2,500 patients. And you can see in many of the reports the progression of fractionation. The longer-term data is with 3 fractions, or sometimes 4, then down to 2, then down to 1. The longest-running consistent fractionation here is Jeff Demanis's data, where he is using 6 fractions of 7.25 gray. This being monotherapy results, these are all low risk and intermediate risk patients. And as the converse of the boost results, the majority of these did not get androgen deprivation. But if you look at Demanis's results, his BNED at 10 years is 98%, which is excellent. Hoskins' data moved from 3 fractions to 2 to 1, and the follow-up varies. It's going to be 9 years for the 3 fractions, 5 for the 2, only 4 years for the single fraction. But again, the results are up in the 90%. So if you scan down here, it all seems to be about mid-90% for the BNED rates. The one exception is Prada's paper, which I'm going to deal with in a bit more detail, where he was reporting on only single fraction 19 gray and had only a 66% BNED rate at 6 years. But we're going to come back to that. In terms of toxicity from the monotherapy, GI grade 3, essentially 0. And it's because you can pull the rectum away from where you're treating the prostate. GU grade 3, all under 5%. Strictures are generally 2 to 3%. So a very acceptable toxicity level. This is from the Japanese paper on monotherapy. Grade 3 toxicity is in green, grade 2 is in blue. As we typically see with GU toxicity, grade 2 toxicity after radiation tends to gradually increase for 10, 15 years. We see it in gynae, we see it in prostate. But the grade 3 toxicity is at a very low level. The GI toxicity, again, is well under 5%. So HDR prostate brachytherapy is a highly effective treatment with low toxicity. The optimal boost dose appears to be quite well established at a single 15 gray. The optimal monotherapy dose and fractionation is still evolving. One of the problems is that the linear quadratic model that we use for calculating biologic equivalence may be less accurate when you get to fraction sizes over 15 gray. And the other really important thing which makes sense here, makes a lot of sense, is when you give a single fraction, you lose the opportunity to take advantage of sensitization by previous treatment. The reoxygenation happens, which is the reason that we always fractionate radiation. The redistribution of cells into sensitive phases of the cell cycle, and also the vast immunologic and transcriptional changes which take place in the tumor after the initial radiation. If you're doing it all in 20 minutes, none of that's going to happen. This is just an HDR monotherapy case I wanted to share with you. 65-year-old man, T1C disease, PSA 7.5, 24 cc prostate, 2 cores positive, 30% pattern 4, both in the transition zone, one 2 millimeters, one 5 millimeters. This man's on a randomized trial between LDR and HDR, so they all get a multiparametric MRI for staging. And this showed a quite large 1.3 by 2 centimeter lesion in the anterior zone of his prostate, PIRADS 5. Because the MRI is only done as part of the trial, we don't get to change the treatment based on what we see on the MRI. His prescribed dose was going to be 2 times 13.5 gray to the whole gland with focal escalation to the dominant lesion because we've identified it on the MRI. So this is quite impressive MRI, and obviously his ultrasound-guided biopsies just kind of touch the tip of this, getting 2 or 3 millimeters of disease and missing the money there. What we do is identify the DIL on the multiparametric MRI, then register that with his ultrasound pre-procedure to transfer that information onto the ultrasound. There's 2 contours here. The pink one is the DIL min, which is where the 2 contours on the ADC map and the T2 overlap, and that's where I direct my biopsies. The purple one is the DIL max, which is where we dose escalate to, and that's the addition of the 2 contours. So I did 2 targeted cores from this lesion. It was pretty easy to hit. Overall, it was 60% pattern 4, and one of the cores was 90 to 95% pattern 4. This is a dosimetry from his first fraction. As I said, the prescribed dose is 13.5 gray, but the D90, the dose to 90% of the DIL, is 18.2 gray in a single fraction, and he'll get that again 2 weeks later. And I think this is what's making HDR monotherapy so effective. So is there an optimal single dose? Single fraction, 15 gray for a boost is okay because then it's followed by the external beam. So the sensitizing effect of that single 15 gray is beneficial to the effectiveness of your subsequent external beam. For single 19 gray as monotherapy, the results are very mixed. Hoskins found that it seemed to be okay at 4 years, but Prada's results is a real wake-up call with only a 66% BNED rate at 6 years. And in confirmation of that, Morton's group in Toronto found a 10% local failure rate within 3 years at the site of the original DIL after using a single 19 gray. And they actually mapped out what dose that area had received, and the D90 to those DILs was as high as 23 gray with a mean dose of 29 gray. So I'm not sure that there is a single HDR dose which is going to be effective. And single dose monotherapy definitely remains investigational at this point. So what is the optimal dose for monotherapy? Demanis uses 6 fractions of 7.25 gray, but it's 2 implants, 2 procedures, 2 hospitalizations with overnight stays. When you get down to 2 fractions, results are maturing for 2 times 13.5 gray. Hoskin had a very satisfactory BNED rate at 93% with 5.2-year median follow-up. Yoshioka, the big Japanese study, only used the 2 fractions for 13% of the patients, but didn't report or detect a difference in efficacy at 6 years compared to what they were using as their more commonly used fractionation. And Jawad reported, this is the Beaumont series, with a 3-year follow-up, a BNED of 90%. So the results are maturing for that, and I think that's safe to use for monotherapy. This is the BED equivalence graph that I was talking about. This is from Yoshioka's paper. 27 gray and 2 is the red line here, which is underneath a lot of the other lines, but you can see with different alpha betas how you can superimpose or create equivalent fractionation schemes. But what happens when you give a single fraction? This is an interesting article from Keem from Australia, which was published this year. Just 5 patients treated with 2 times 10 gray, 2 weeks apart. They biopsied before the first fraction and 2 weeks later before the second fraction, and then used genome-wide 3' RNA sequencing on the total RNA from these 10 biopsies for quantitative expression data for 13,000 genes. And they found over 1.5-fold upregulation or downregulation in over 80% of the samples. So there was strong upregulation of the p53 pathway, interstitial remodeling, extracellular matrix proteins, focal adhesion pathways, and inflammation are all strongly upregulated. And they found clustering of changes inherent in apoptosis, programmed cell death, extracellular matrix organization, and immune regulation. So if you look at graphs here for biologic process genes, molecular functions, and cell localization, and along the y-axis here you can see, or actually x-axis, you can see like 2-fold enhancement, 4-fold enhancement. So these genes are really, really strongly upregulated 2 weeks after a 10 gray fraction of HDR. And this shows the clustering effect of upregulated genes. This is 449 upregulated genes. These are, this is a cluster of genes that are upregulated for apoptosis, for inflammatory response, for regulation of signaling. I mean, there's a whole lot of stuff going on in there. I'm not an expert in this area, but these are extremely important changes that we don't get if you give HDR as a single fraction by itself. So in terms of future directions, incorporation of the results of advanced imaging with multiparametric MRI into treatment planning and workflow allows focal dose escalation, which can be very easily performed to sites of dominant disease. The multiparametric MRI truss fusion is feasible for this purpose. It adds less than 10 minutes to the total procedure time, and with no change in the standard technique of ultrasound-based needle guidance and planning. And you can get very precise dose painting to the targets within the prostate. In terms of fractionation, 15 gray is the standard for a boost when it's followed by external beam. For monotherapy, I think it's safe to go with the 2 × 13.5 gray, but not as a single fraction. Thank you.